How are you?
How are you? Good afternoon.
Yeah, good. Would you please introduce your team and your case?
Okay.
Yeah.
Welcome to the third live case in SNU Hospital. I'm H.S. Kim from SNU Hospital. My co-operator, Dr. B.K. Gu, and J.Q. Han, and Jiun Gang. Before starting the TAVI case, I'd like to summarize the previous CTO case. It takes 2 hours to finish the procedure. If you remember, there is very difficulty to pass the retrograde microcatheter through septal channel. Thus, I tried 3 options. The first, retroguiding catheter backup improvement by anchor balloon to RV branch as shown here. And then I changed ENCORE SEOUL to Carabel. It does not pass. Thus, I performed the septal ballooning with 10 millimeter balloon. Then Carabel passed through the septal channel to the mid LAD plus. Then I introduced the retrograde Carabel further plus. Then tip injection, but dissection at mid LAD happened due to tip injection or retrograde guide wire. But retrograde wire is a very soft one. Plus, then I changed the retrograde wire and cautious navigate retrogradely, and the wire entered the proximal true lumen, as shown here. Plus, then I introduced the retro wire into the antegrading guiding catheter, plus. As shown here. Okay, the guide wire entered antegrade wire guiding catheter, plus then externalization was performed, then antegrade ballooning was performed, 2.5 balloon, plus. For the safety, I put the second wire into the 2 distal LAD using Crusade, as shown here, because there is a segmental dissection at mid part of LAD. Thus, I passed the second wire into the distal LAD, plus, then perform a distal first stenting, plus, inflation, plus. Here, we can make sure that dissection does not propagate, plus. Then I put the second wire to the big diagonal for the safety, plus. Then I put the second proximal stent, 3038 Zions Alpine, plus. Adjunctive ballooning with maximal pressure. Make sure no indentation, plus. Then this is view after stenting, plus, to make sure the safety of septal channel that underwent balloon dilatation, plus. I put retrograde wire and remove the Carabel catheter and angio. Make sure there is no leakage of the septal channel that underwent balloon dilatation. Plus, then all the removal of the catheter and wire, I checked angiography. It's wonderful. Plus, the beauty is that there is no loss of side branches. That is a beauty of both grade approach, retrograde and antegrade approach, to minimize the segment of subintimal tracking. This is the final angel. Can I show you the final slides? Here's a summary of the previous CTO case. Guiding catheter I used retrograde AR17 French. It should be 8 French as my routine practice. But we recognize there is a good septal channel, thus 7 French backup would be enough. But visible septal channel has a trick point. It's very acute band. Thus, finally, we navigate through the smaller septal channel. That requires 8 French backup. Guide wire passed with Sion through septal surfing. Sometimes, if there is numerous septal channels, you can reach through this lumen by just septal surfing. That happened in this case also. Retro microcatheter could not test. There is some not so infrequent case. In this situation, there are 3 options. Anchor balloon for retrograde guiding catheter to improve the backup force, or change to another microcatheter, Corsair to Caravelle, or vice versa. And finally, ballooning of septal channel with 1-0 balloon. I finalized this case with 2 stent with Zions Alpine. This is previous case summary. And then I'd like to change the presentation of today's third live case.
Yeah, good job, Dr. Kim, and congratulations. Yeah, let's move to the next case.
This TAVI case, 81 years old female, complained dizziness for 1 year. She was diagnosed with hemolytic anemia due to severe stenosis of failed aortic valve. TAVA, SAVA was recommended. She underwent AVR with Carpentier-Edwards Perimount Magna 21 millimeter valve for CVAS, at that time bicuspid, 13 years ago. During operation, spontaneous aortic dissection happened, and she underwent ascending aorta and hemi-arch replacement. That is a very important hurdle for this procedure today. TS doctor in charge of her recommended TAVI in SNUH. Then she visited me. Plus, age 81, a typical candidate for TAVI, small habitus, but normal BMI. She had VATS twice due to lung cancer. Medications, prostate aortic valve stenosis with trivial leakage with TAVI. Plus, SS score is more than 8%, high surgical risk. Plus, Coombs negative hemolytic anemia. Hemoglobin is about 6.9. When we trace the change of hemoglobin for recent 13 years, plus here, 13 years, hemoglobin decline as time passes, as aortic stenosis aggravates. Thus, we expect the cause of hemolytic anemia may be due to aortic stenosis, which was very severe today. Plus, lung good. PR interval is very prolonged due to previous surgery. Plus, AV max 4, AV mean pressure rate 40, LV function totally normal. Plus, aorta CT angiogram, extensive aortic dissection happened 13 years ago, from arch to distal abdominal aorta. That is one issue in this case. Plus, but there is a true and false lumen stable for 13 years, but it looks very unstable. Thus, we paid a very cautious attention to advance the sheath into distal aorta. Plus, yeah. Right iliofemoral artery CT looks fine, except for distal aortic dissection. Plus, minimum size is 7.0. Okay, plus. Left iliofemoral artery, there is a huge dissection on the distal aorta. Plus, size 6 millimeter minimum. Plus, cross-section of prosthetic valve, Magana 21, actual internal diameter is very important. That was 18.4 millimeter plus coronary height 10 or 15. Luckily, it is above the coronary ostium. There is higher chance of coronary obstruction in VF TAVI. Thus, that is one of our concerns. Plus, to summarize measurement, internal diameter 8.4 millimeter. New annulus perimeter is less than 60 millimeter. Plus, we chose core valve, and the perimeter about 60 millimeter corresponds to 23 millimeter avolator with 25% oversizing. Plus, so I prepare 5 issues in this case. The first one is valve-in-valve TAVI for failed surgical aortic valve. The important thing is, if there is a severe paravalvular leakage, TAVI does not help. But in this case, mainly transvalvular aortic stenosis. To identify failed surgical valve is very important. That was Magana 21. Which type valve is appropriate? Internal diameter is 18.4 millimeter. That can cover with smallest avolator or smallest sapien 3. But I prefer supraannular design avolator in case of VF TAVI. Is a bioprosthetic valve fracture required? Sometimes it is required, but in this case, internal diameter is 18 millimeter, perimeter about 16 millimeter. That is in the range of cover by avolator 23. Thus, I don't think it is necessary to do BVF. I expect residual pressure gradient less than 20 millimeter of mercury in this rationale. Most important thing is safety, aortic dissection, and prolonged PR interval. But luckily, VF TAVI, complete AV block is very low because of the protection of failed surgical ring that protects against the expansile force of avolator. Thus, I don't expect there is a complete AV block. Then I will show you the angio taken until now. Angio, please. Here, puncture under fluoroscopic guidance, plus. This is artography with ideal angle, with tangential angle to see 3 struts of failed surgical valve as a single plane. That is our working plane. Plus, it is very important to make sure the advancement of all catheter wire through lumen. Thus, we made a special precaution. Plus, an advanced terumo and advanced protective catheter into ascending aorta, plus. Then we advanced Safari wire for the introduction of big sheath, plus. Make sure all the wire in the true lumen by angio and by TEE, we introduce big sheath, plus like this, very cautiously. There is some calcification in the artery, but without any significant resistance, we can pass the sheath. Cautiously, plus. You can see the dissection shadow at the distal aorta. Plus. Then, when retrieve of Safari wire, we also use protective catheter to avoid the damage to the dissected aorta, plus. So we remove the supply wire under protection of another catheter, plus, like this, okay, plus. All the exchange happened ascending aorta for the safety. Plus, plus. Then advanced wire, it was very difficult. Plus, I changed the introduced wire to Judkin, right? Plus. Then passed plus. Then introduced the pigtail catheter into left ventricle, plus. Plus. This is the last image. And then double tracing, we recognize again severe stenosis. Here, peak pressure 250 lV, peak pressure 125/30 in aorta. It's a big difference. That may cause hemolytic anemia. Okay, is there any comment, question on this case?
Okay, thank you, Dr.
Could I-
Kim. Any
could I have-
questions, comments?
Could I have one
Okay,
comment?
yeah.
Hello, Professor Kim. This is Hyo-Soo speaking.
Yeah.
Thank you for sharing your very nice case. One question that will, just facilitate the discussion. This patient had aortic dissection, as you mentioned, and according to the CT scan, I thought subclavian access would be very feasible. And I understand that you went very cautious, very careful with transfemoral approach. But as you inserted the Safari wire, there's a bend in the catheter in the aorta. So, dissected aorta is somewhat fragile. So why did your heart team consider performing subclavian in this particular case? Very nice access, I would say.
That is another option. There are two reasons. First, I think I can pass the whole system safely, seeing the 4 central lumen. The second reason is we don't have any experience with subclavian catheter TAVI procedure. Thus, I think it is possible to do a transfemoral approach under precaution. That's the reason why we decided to do transfemoral TAVI. And as we expected, it is not so difficult.
Can I ask a question?
Okay, please, can you show them the TE image? We monitor the existence of device in the true lumen by TE assessment. TE image conversion.
T로 보내주세요. Okay.
Here, in the upper chamber is true lumen. You can see color Doppler. In the lower chamber with thrombus is false lumen. Two devices are in the true lumen. Okay.
Can I ask a question?
Then we are going to proceed the process. Change to die. Okay.
Dr. Kim, somebody has a question.
Dr. Kim, are you concerned about possible coronary obstruction? So the height of left coronary system is 10 millimeters.
Increased volume.
So
I
did you
cannot-
measure the distance between the post and the takeoff of the left coronary artery to see whether there is enough space to accommodate the valve and not run the risk to have a coronary obstruction?
그 increased volume for my earphone.
여기 화면 좀 바꿔주세요. 오른쪽 화면.
Do you mean the risk of coronary obstruction, especially at left main? Left coronary artery. Height is a little bit low. Okay, that is another option. Can you see the root arterography once again? root arterography.
플러스. 요거 run.
there is possibility of coronary obstruction in left side.
Once in the T, we can also see that the LCA os is right above one of the vertical shafts of the previous magnum aortic valve. So,
Dr. Jiun Kang mentioned at the TE assessment, one strut of failed surgical valve height is below left main.
T 화면을 방송으로 보여드릴게요.
Can you show you the image
okay.
support?
yes, this is the image that we have for. Right here, we can see an active blood flow that is inserting the left coronary artery. And this is showing where the LCA os is.
So can you see the height of strut of failed surgical valve and the left main?
Yes.
So we can get sure that even though the surgical valve strut is reflected outside, it cannot reach left main ostium. That is another beauty of TEE. That's the reason why our team likes general anesthesia, not conscious sedation. Of course, if it is required, we perform TAVI under conscious sedation, but not routinely, because in our cath lab, there's no severe traffic jam like Western cath lab. So I'd like to emphasize the importance of TE. Okay, Flora once again.
바깥에 화면 바꾸세요.
So I introduce supply wire to left ventricle.
방송화면, 방송. 오케이.
Okay.
Dr. Kim, are you going to pre-dilate the valve? Pre-dilation?
No.
No, just direct
밸브
stenting.
믿었죠? 밸브 네. 밸브 주세요. 네. 자, 잠깐만. 자, Y 잡으세요.
자기 혼자 네. So we are now doing inspection of crimped avlotal. 돌려보세요. Okay, we can see the paddle and pocket. No distortion of valve frame. Okay, you'd like to use this one.
포트가 위로 가. 컨타미네이션 안 되게 조심하세요. 뒤에 조심. Y 나왔습니다. 잡았습니다.
Why stay?
T 조금 빼주세요.
Okay, LAO. Then I'd like to advance cautiously whole system. Okay, the best angle.
틱트 조금 밀렸습니다.
Storage.
저장했죠? 오케이. T 조금만 빼주세요.
Coaxial angle is not good. In this case, I usually push the wire, simultaneously push the system to make it line. Okay, it's not good. Okay. It's a very tough case. My target is 4 mm ventricular. How about pressure? It's okay. Okay.
100.
Deploy.
Deploy. Deploy. Deploy. Deploy. Deploy. Deploy. Deploy. Deploy. Deploy.
Stop.
Stop.
조정하고요. Here is the progress. It's good, but the bad thing is coaxiality is very bad due to horizontal heart. Okay, deploy.
Deploy. Deploy.
Deploy.
Deploy. Deploy. 열립니다.
Stop.
Stop.
조정. Okay, can he make pacing to 100?
Facing.
Because there is some premature beat. In that case, pacing would be very helpful. 100.
Back.
Okay. Okay, retrieve.
Deploy.
No.
Deploy.
그럼 할 필요 없어. 플러스.
열립니다.
네.
Deploy.
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 Stop.
Stop.
저장.
혈압 110입니다.
It looks good. Okay. Deploy.
잠시합니다. Deploy. 혈압 봐주세요.
네, 다시
Deploy.
106 그대로입니다.
Deploy.
Deploy.
Stop.
Stop.
저장.
혈압 조금 떨어졌습니다. 90 조금 떨어졌습니다.
Okay, deploy.
Deploy. Deploy. Deploy. Deploy.
혈압 100입니다. 괜찮습니다.
Deploy. Deploy.
Stop.
혈압 떨어지기 시작합니다. 90.
저장.
85입니다.
Deploy.
네. Deploy. 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 Deploy.
다시 올라갑니다.
천천히 하겠습니다.
저장. A little bit deep or okay? Okay. More deploy.
Deploy.
More.
Deploy.
More. Okay. 저장.
I
Facing
think,
off.
I think the valve's very nicely self-centered, and the NCC side looks pretty nice, but maybe the left side is a little bit deeper as you aimed, and there's a little chance of remaining gradient with this 21 surgical valve. So I know it's difficult with this horizontal type aorta, but I would try to recapture and aim a little bit higher implantation.
Okay. How many minutes remain?
몇 분 남았어요?
Can you see the T?
7분 남았습니다.
뒤에 보이세요?
Okay, we can assess T.
저 화면 T 보이시고
Yeah, we can see.
Just put the
yes.
color.
컬러. 네, 컬러 넣어주세요.
This is the T in the long axis view, and we can see some AR. And going to the short axis view, there is some AR in the right side of the implanted aortic valve.
How about depth, longitudinal view,
Okay, I'm going back to
relation
the
with mitral valve?
the depth seems pretty okay. There's no interference with the mitral valve movement in TEE.
Okay, in terms of residual pressure gradient, we try our best to implant as high as possible. Okay, try recapture.
Dr. Kim?
Yes, let us show you the angio.
엔지오 스크린 또 보여주세요.
Angio. This is the last picture that you've seen. This is the first trial of deployment. Ventral depth is left about 4, right about 8. Thus, we recapture the valve plus. This is recapture process usually associated with hemodynamic instability. So we don't like recapture, but for the long-term benefit for the patients, we just try recapture and redeploy plus. Once again, try to redeploy. I usually control the depth by 2 hands. Right hand to control the wire, left hand to control the delivery system. Okay, stable plus. Check. Until now, depth is good, perfect plus. The difficult thing is malalignment between delivery sheaths and horizontal aorta. Very stable. On the 100 BPM pacing plus. Still good plus. Continued deployment. So I maintain the tension. This process is very unstable at this stage. Dive in or pop off. Plus, once again, looks better than previous one. Plus, so we a little bit wait and deploy before no return point. Plus, once again, looks better. Then we finally release the valve. Plus, cautiously, a little bit release of tension, just only stiff wire. Very slowly, very slowly. Okay, make sure all the pedal is released, plus. Okay, plus. Then we perform angiography. Coronary artery is good. Depth is really good. Left 2 millimeter, right 6 millimeter. And there is mild regurgitation. We check it, regurgitation between 2 valves or outside the surgical valve. It is between 2 valves. Thus, we perform post-ill. Plus, here is balloon positioning. Plus, and performed balloon dilatation with 20 millimeter balloon. Even we input the maximum volume, the actual dilatation is about 19 millimeter. Internal diameter of that valve is 18.5. Thus, with this post-ill, we make it possible to eliminate the space between 2 valves, TAVI and surgical valve. Plus, remove the balloon. Plus, then angio, remarkably better with the maintenance of the optimal ventricular depth. Then we check the TEE. TEE, please. TEE echo, okay.
Yes, this is a TEE after the first implantation, and we can see that there is some regurgitation from 2 o'clock to 4 o'clock. And then after the additional ballooning, we can see that the regurgitation has reduced to a mild degree.
Just
And-
2 or 3 o'clock pinpoint regurgitation.
And just for your interest, some of us have shown that this is after the wire, after we remove the wire, and we can see that the air has decreased more. And as some of us were worried about the left main ostium, we can see that in this image that we see the previous magna aortic valve strut and the left main ostium, which is patent after the final valve implantation.
You can see the red blood flow to the left main ostium. That is beyond the surgical valve strut. Can you see the cross-section image again? There is a pinpoint regurgitation at 2 and 3 o'clock, even after post-dilatation. That may be due to a kind of eccentric pannus formation inside the prosthetic valve. But it is acceptable because we already performed the balloon dilatation of using 20 millimeter balloon. And more important thing is slide 비춰줄까요? As you can see, before TAVI, there is pressure gradient about 125. And diastolic aortic pressure is very low due to stiff aorta. But after TAVI, pressure gradient is negligible. That tells us there is not necessary to do any further maneuver. No residual pressure gradient due to high implantation with supraannular design valve and additional ballooning. Let's look at the diastolic aortic pressure. Still low, but it is higher than previous one. AR index before TAVI, just 12. After TAVI, 20. Even though there is a negligible leakage, that is a limitation of AR index. That is confounded by several other factors, especially by stiffness aorta. Okay, angio once again. Plus, this is aortography with right side. Still good. Ventricular depth is look even better. Plus, on the left side, good. As time passes, the leakage will decline in case of evolotol. Thus, I'd like to show you the real-time angiography to see further declining of leakage.
뒤 좀 빼주세요. 강생 티 조금 더 빼주세요.
Okay, angio, snap, shoot. Still good. Left 쪽으로 좀 해볼까?
So Professor Kim and all the team members, congratulations for the beautiful case. You've beautifully shown the recapturability of this valve, evolute art, and I think on top of it, the post-dilatation was really effective.
This is final angio.
Oh, well,
Thus,
okay. Thank you very much, Dr. Kim, and thank you for your excellent presentation, your procedures. I think you made a very good job this afternoon, and thank you. And any last comments or questions from the floor?
One question. Which kind of antithrombotic therapy will you give to the patient?
this patient has sinus rhythm, thus I just maintain DAPT indefinitely if permitted.
Why indefinitely?
there are higher prevalence than we expected of subclinical leaflet thrombosis. Thus, if patient is well tolerated, I usually believe in DAPT that is stronger than monotherapy. Of course, I prefer anticoagulant in case of atrial fibrillation indicated, but in this case, I think DAPT would be enough. But monotherapy may be a little bit dangerous in terms of durability of valve leaflet, because I believe durability of valve leaflet may be affected by the position of minute thrombi that may form organoid or fibrotic change followed. Thus, I'd like to make the level of cholesterol as low as possible and strong antiplatelet inhibition if patient tolerate.
Okay, thank you, Dr. Kim. How about move to the Samsung Hospital now?
Okay, Dr. Kim, I think because of a time constraint, we need to go back to the Samsung's case. Thank you for showing us a great case, and congratulations on the excellent result. And thank you for your contribution.
Thank you. Thank you very much for your nice comments.